virtual world. Well, thank you everyone for joining us. It gives me super great pleasure to announce our second person in this annual series, this Women's Health Seminar series. Before I get to introducing Dr. Hilary Brown, I'd just like to do a territorial acknowledgement. So I want to recognize that we live, work, play, and participate on a community of the unceded, ceded, and traditional territories of the 203 First Nations, along with 38 Métis chartered communities, each of which possess their own unique traditions and history here on this land that I am on, that we now refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action. In fact, there'll be a National Day of Truth and Reconciliation this week on September 30th. The United Nations Declaration on the Rights of Indigenous Peoples and the BC Declaration on the Rights of Indigenous Peoples Act. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I'm joining you from Vancouver, North Vancouver actually, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Oh, and I just thought I'd give you a very brief overview of the Women's Health Cluster. It's free to join. As probably many of you already know, we have over 300 members. We run a number of community events and academic events. There's a research trainee presentation series occurring sometime soon. So take a look at our announcements for that. I think it might be this week as well. And we couldn't do this without the support of our sponsors. So please become a member, consider being a sponsor as well. We also give out a number of awards. There'll be another one announcement coming out quite soon. It's just for trainees, and we call them travel awards, but obviously right now travel's not the right term for it, so we'll have to come up with a new term for that. But take a look out for those that'll be announced soon. So you're going to see me looking down perhaps as I'll keep my camera on because I'll be tweeting as I can during Dr. Hilary Brown's talk. So right now I'm going to give a little bio about Dr. Brown while she starts to share her slides. So Dr. Hilary Brown is an assistant professor at the University of Toronto in the Department of Health and Society and the Dalla Lana School of Public Health. She's also an adjunct scientist at Women's College Hospital and ICES. Maybe she'll tell us what the acronym stands for. She holds a Tier 2 Canada Research Chair in Disability and Reproductive Health. Her research program uses epidemiological. Okay. Oh my gosh, I can't speak today. Epidemiological. It's not illogical. Epidemiologic methods to examine maternal and child health and mental health across a life course with a particular focus on populations with disabilities and chronic disease. Sorry, that was very embarrassing. And fun fact, if Dr. Brown, I always like to give a fun fact, as you know, I'll be, the hashtag is WHSS if you want to follow along on Twitter. I forgot to say that. And Dr. Brown's fun fact is if she wasn't an epidemiologist, she would have been a piano teacher. So without further ado, which is pretty interesting, she must also play a mean piano. So maybe she'll play a little bit something for us during the talk. Without any further ado, Dr. Hilary Brown. You're muted still.
Thank you. And I just realized as I shared my slides, for some reason, they've done that funny thing where a timer is on them and I'm not sure how to stop the timer. So I'm going to try my best. I don't know how that was added, but
use timing. Maybe uncheck the use timings right there. See on the top, very top right there, use timing.
Oh, how did that get checked? Thank you. You're a genius. Perfect. Okay.
I don't know if it'll work, but let's try.
Yes, I think that's it. I'm not sure how that got clicked, but hopefully that works. So thank you very much for the invitation and for the opportunity to be here. I'm really happy to be able to share some work I've been doing on chronic physical conditions and perinatal mental health and addiction. So by way of a little bit of background, perinatal mental illness is a condition that has considerable public health importance. This is a condition that's experienced by nearly 20% of women in pregnancy or postpartum. So nearly 1 in 5 women experience some sort of mental health condition, either during pregnancy or within the first year after childbirth. Perinatal mental illness also has considerable implications for both mothers and for children as well. For mothers, it increases the risk of long-term chronic mental illness, as well as increased risk of suicidality in the perinatal period. And for children, perinatal mental illness also has an impact in terms of increasing the risk of behavioral, social, and mental health problems in children as well. However, even though we know how important and long-lasting these effects can be, only about 33% of women with perinatal mental illness actually receive appropriate psychiatric care. So there's a considerable burden of mental illness in the population that is not addressed for women in pregnancy in the postpartum period. There's a lot of research looking at risk factors for perinatal mental illness, and we know that some of the strongest risk factors include a history of mental illness or addiction prior to pregnancy, stressful life events, as well as poor social support. But even though there's been really consistent research showing how important these factors are, and even though there are lots of interventions that try to address especially social support and stress, rates of perinatal mental illness are not decreasing in the population. And so there's a real need to understand additional risk factors and additional potential high-risk populations who could be targeted to receive more appropriate supports to prevent perinatal mental illness. So this leads me to the rationale for this research. So outside of perinatal populations, in the general population, we know that there's growing evidence of a bidirectional relationship between mental illness and addiction with chronic physical conditions. So for example, there's a growing body of literature showing that people with diabetes, cardiovascular disease, and other chronic conditions are at increased risk for depression and anxiety and other mental illnesses, and vice versa. So the opposite is also true, that people with mental illness or addiction are also at increased risk for chronic physical conditions. There's many potential mechanisms that have been explored and that continue to be explored. For example, many chronic conditions are characterized by chronic inflammation, by vascular pathology, by HPA axis dysfunction. These sort of aspects of the pathophysiology of chronic physical conditions are also implicated in mental illness as well. And there's also some preliminary evidence to suggest that some physical conditions and mental illnesses also have some shared genetic factors. So there's a biologically plausible relationship between chronic physical conditions and mental illness and addiction. And there's also a social component to it as well, in the sense that if you are managing a chronic physical condition, the stress associated with pain, fatigue, sleeplessness, and even just sort of general illness management also increases the risk for depression and anxiety from a stress sort of point of view. And so this is an important area of research that's received quite a bit of attention outside of the perinatal period, and growing sort of understanding of the need for co-management of physical and mental illnesses, again in the general population, but has not received as much attention in perinatal populations. So when we started out doing some of this research, one of the first steps was to understand what research had been done to understand the relationship between physical conditions and perinatal mental illness in perinatal populations, and what the sort of major limitations of that research was to understand what could be done to better understand the association. So a couple of years ago now, we did a meta-analysis of 12 studies, including just about over 1.5 million women from the individual studies, that showed that indeed there is preliminary evidence to suggest that having a chronic physical condition does increase the risk for mental illness in the perinatal period, including mental illness in both pregnancy as well as mental illness in postpartum. But one of the major limitations of these studies is that they didn't do a very good job of trying to disentangle whether chronic physical conditions were a risk factor for new onset mental illness, or if it was just sort of a signal to suggest that women who entered pregnancy with a physical condition and a pre-existing mental illness sort of continued to have problems and continued to experience symptoms of both conditions in the perinatal period. So in other words, there was very little work that had been done to really understand kind of the temporality of these associations and whether physical conditions could be a risk factor for new onset mental illness in the perinatal period. Likewise, we looked for research looking at relationships in the opposite direction. So could a history of perinatal mental illness be a risk factor for development of new onset physical conditions across the life course for women? And there's even less research on an association in this direction. Just recently, there was a Danish study showing increased risk of chronic physical conditions and premature mortality due to natural causes, so due to disease as opposed to an event such as suicide. So there is preliminary research to show that women who have a history of perinatal mental illness are at increased risk for chronic disease later in life. And there's also been a handful of studies also showing elevated risk of autoimmune disease, specifically among women with a history of perinatal mental illness. So combining these two sort of sets of information together, it seems that there could plausibly be an association such that women with a history of physical disease are at increased risk for mental illness in the perinatal period, and likewise women with perinatal mental illness who have not previously had a physical condition could be at increased risk for that condition later in life. So that brings me to the objectives for my talk today. So I'll be exploring the association between chronic physical conditions and perinatal mental illness using 3 specific examples from some of our ongoing and completed research. So the first study that I'm going to talk to you about is looking at pre-existing diabetes and the risk of new onset mental illness in the perinatal period. I'll also talk about a study that we did looking at chronic disease more broadly and the risk of perinatal substance use disorders. And then finally, I'll talk very briefly about some research that we've done looking at perinatal mental illness as a risk factor for future autoimmune disease. So 3 separate studies, each of which has in common this sort of relationship between physical and mental illness as it pertains to what is happening during the perinatal period. So I'm going to keep the methods fairly high level and just focus mostly on sort of findings and take-home messages. But I do want to very briefly introduce the data that we use in Ontario. So ICES is the source of health administrative data that we use in Ontario. Formerly, ICES was the Institute for Clinical Evaluative Sciences, but for some reason we decided we wanted to be like IBM or BMW, where we are only known as our acronyms. So that's the reason why that was not spelled out in my bio. But this is the source of health administrative data that we have for all Ontario residents. We've got a population of about 14.6, I think it's almost 14.7 million residents in Ontario, of which we have about 140,000 births per year. And the administrative data that we have is really unique, especially compared to a lot of research in the States and elsewhere that relies on sort of snapshots in time, where in Ontario, we have these data sets dating back as far as 1988, where we're able to link all emergency department visits, hospitalizations, as well as physician visits, with some basic sociodemographic data from the medical chart, as well as neighborhood level data from census information. We're able to link this information over time, again, from the late 1980s until now. So, 30 plus years of data. And we're also able to link maternal and child data. So that's really beneficial as well, for the purposes of this study, at least, to be able to identify births and to be able to identify some complications around the perinatal period as well. So that data source is the basis for all of the cohort studies that I'm going to be speaking about today. And if you have specific questions on methods, I'm happy to answer them either as we go or at the end. Okay. So starting with our first question about whether a history of diabetes increased the risk of perinatal mental illness. So for each of these, I'll give just a tiny bit of information on kind of the plausibility of the relationship and the importance of studying these specific sort of connections within our broader topic of interest. So diabetes is of particular interest in that it is a common chronic condition impacting reproductive age women, affecting about 3% of women in their childbearing years. Diabetes is a really interesting chronic condition to study in this context because there is some evidence to suggest that diabetes can actually produce some notable changes to the brain, including changes in blood flow and potentially even some cerebral atrophy. And so that has particular importance when we're talking about conditions such as mental illness, when we know that sort of brain pathology is implicated. Diabetes is also one of those many chronic conditions that is characterized by a chronic pro-inflammatory state, which might be another factor that might also increase the risk of mental illness. So again, this is an interesting one to study from the perspective of a group that might be at increased risk for mental illness in the perinatal period. So for this specific study, thinking about that overall data set that I mentioned, what we did for this specific study was to look at women with a singleton birth over a 10-year period from 2005 to 2015. And we looked specifically at women with no recent mental health care in the 2 years prior to pregnancy. We did include women who had a longer term history of mental illness, sort of 2+ years prior to pregnancy, with the rationale that if mental illness is a relapsing and remitting disease, that we might expect that the perinatal period could be a time of increased risk for new onset mental illness, but also for relapse of mental illness that had previously been well controlled and had sort of been dealt with. So is it a time when someone might experience a relapse? In terms of the chronic condition that we were interested in, again, we were interested in diabetes specifically. And we also wanted to try to tease apart as best as we can within the confines of administrative data, some of the disease and care-related characteristics of diabetes that could influence mental illness risk. And I'll go into a bit more detail on this in the next slide, but we were basically interested in diabetes control. And if someone with worse diabetes control would have sort of even greater increased risk for mental illness. And then in terms of our outcome, we were interested in the occurrence of any mental illness. So again, any sort of new mental illness or relapse mental illness between conception and the end of the first year postpartum. And then we also looked at mental illness according to whether the first contact for mental illness was in pregnancy versus postpartum separately. And then according to the specific diagnosis that was made, whether it was a mood or anxiety disorder, psychotic disorder, or other mental illness. So this is just a little bit more detail on the diabetes piece that I mentioned. We used a process called latent class analysis to divide our diabetes cohort according to underlying characteristics of the women. So according to how long they had had diabetes, whether they also had diabetes complications. So for example, diabetic crises that might send you to the ED, whether they had any sort of comorbidities like cardiovascular disease, whether they used an insulin pump, and then how well their diabetes was monitored. So according to sort of ongoing Diabetes Canada guidelines, whether they'd received the number of tests that they should have had in the last couple of years, both sort of overall related to diabetes, but also related to things like eye exams. So again, just sort of a, I guess, sort of crude measure of how well their diabetes was being taken care of. And what we really see from the data is that we have these three sort of groups of people with diabetes entering pregnancy. We have class 1, which is a group of people who are sort of uncomplicated and not receiving regular care, perhaps because they are uncomplicated in terms of their disease. Class 2 is a group with complicated, long-standing diabetes. Most of them had had it for more than 5 years and receiving regular care. And then class 3 was more recently diagnosed with comorbidities and also receiving regular care. So this is sort of what those three groups look like. So I'm going to show you a couple of tables looking at the findings. I know that not everybody here is an epidemiologist, so I'll just spend a second kind of orienting you to the data that we're looking at. So what we're really looking at is the relative risk of mental illness or perinatal mental illness comparing any diabetes as well as the specific diabetes classes to people without diabetes, where a relative risk of 1 or greater indicates elevated risk in our exposed groups of interest. And we've got 95% confidence intervals around those estimates. And as long as those intervals are above 1, then that tells us that there's a statistically significant difference. And we looked at these risks overall and as well adjusted for things like age, parity, income quintile, where people lived, whether it was rural or urban, and then whether they had a remote history of mental health care. So what we're really seeing is that there is a pretty consistent relationship in terms of a small but statistically significant association between any diabetes and any risk of perinatal mental illness overall. But interestingly, it seemed like it didn't really matter what the underlying disease characteristics were of the diabetes. All of the relative risks are sort of around the same magnitude, suggesting that diabetes was a risk factor regardless of sort of how well it was managed. And I'll get into some of the nuances about, how we interpret that and whether it could be kind of more of a specificity of what we're able to measure in our data. But in any case, what we're seeing is a pretty consistent relationship between diabetes and perinatal mental illness. We see also that this relationship holds for onset of mental illness in the prenatal period, as well as the postpartum period. Perhaps a slightly greater risk in the postpartum period, but not so big a difference that we would really make too much of it. And then we also see that there was consistently elevated risk for both mood or anxiety disorders, as well as psychotic disorders. And I did not include it on this slide just to keep things simple, but we saw similar relative risks for kind of a catch-all of other mental illness, sort of anything other than mood, anxiety, or psychotic mental illnesses. Okay, so that's our first study. So again, sort of evidence suggesting that there is an association between diabetes and perinatal mental illness. So we were also interested in whether this relationship also extended to substance use disorders. So again, outside of pregnancy, there are studies showing a fairly strong co-occurrence of chronic physical conditions and substance use disorders in the general population. And again, there's many sort of intricate reasons why this may be. One potential reason is that we know that many chronic conditions, especially musculoskeletal conditions, are characterized by chronic pain. And this can result in substance use disorders through, harmful use of prescription drugs. And then there's also this sort of broader social relationship where if you think of all the stressors associated with chronic disease, the fact that there's a lot of overlap with poverty, as there is for substance use disorder, a lot of these things just tend to cluster together. And so we were wondering whether chronic conditions were risk factors for substance use disorders in the perinatal period as well. So again, just a sort of very brief overview of the methods of this study. For this one, again, we looked at about a 15-year period of women with singleton births in Ontario. This time we looked broadly at any chronic physical condition, and we also looked according to the body system that was affected, so musculoskeletal, et cetera. And then as our outcome, we were interested in any substance use disorder with sort of onset between conception and 365 days postpartum. And again, we looked according to the timing of that substance use disorder, as well as the type broken down according to whether it was substance use related to harmful use of drugs or alcohol. So same sort of data as what I showed to you previously in terms of interpretation of these data. So what we see is that substance use disorders overall are quite rare in the perinatal period, especially when we're relying on administrative data, where it's really, the people who were able to access care for that substance use disorder. But we see quite a strong relationship between chronic conditions and substance use disorders in the perinatal period. The relative risk does drop considerably after we control for covariates, especially that remote history of mental health care and substance use disorder healthcare, but it doesn't completely disappear. So there was kind of a remaining relationship between chronic conditions and substance use disorders, even after accounting for any history, remote history of substance use disorders and other covariates. Again, thinking about this in terms of timing, again, there was quite a strong unadjusted relationship with substance use disorders in pregnancy as well as postpartum. And again, the relationship did decrease in magnitude after accounting for covariates, but it did remain with relative risks of about 1.3 for both of those periods. Looking at type of perinatal substance use disorder, the relationship persisted for both harmful use of drugs as well as harmful use of alcohol. And then we also looked at whether the relationship persisted with and without perinatal mental illness comorbidity, because one of the questions we sort of had was, is this just a matter of who is getting picked up in the perinatal period? And does it tend to only be women who are also being seen, for example, for a perinatal mental illness? Or is it also something where these folks are getting picked up if they only had a substance use disorder diagnosis? And so what we see is that the relationship is fairly strong looking at comorbidities, so the occurrence of perinatal mental illness as well as substance use disorders in the perinatal period. And it's quite a bit weaker when we only look at when we look at people who only have perinatal substance use disorders without a comorbid perinatal mental illness diagnosis, but the relationship does not disappear. So there was a small but significant relationship for substance use disorders on their own. Okay. So then the third example that I wanted to talk about was the impact of perinatal mental illness on autoimmune disease risk later in life. And so now we're sort of flipping the relationship before. For the first two examples, we were interested in whether history of chronic disease increases the risk for mental illness in the perinatal period. Again, now we're flipping it around and we're interested in whether perinatal mental illness increases the risk of future autoimmune disease. So why might we be interested in autoimmune disease specifically? Autoimmune diseases are really interesting in that they are impacted by pregnancy. And so, you know, the hormonal changes that we see associated with pregnancy and the immunologic responses to implantation and delivery really sort of change the nature of autoimmune disease activity, where pregnancy itself is a risk factor for autoimmune disease. And it's also a risk factor for worsening autoimmune disease, especially around the time of delivery in the early postpartum period. Now, interestingly, perinatal mental illness is also most common in the early postpartum period as well. So there's a lot of actual similarities between perinatal mental illness and autoimmune disease in terms of the ebbs and flows of disease severity across the perinatal period. And as well, both types of conditions are characterized again by those inflammatory markers. And so one might ask, you know, whether perinatal mental illness is itself autoimmune in nature and therefore might increase the risk of autoimmune disease later in life. And so for this particular cohort study, now we're sort of changing the methods a little bit in that, you know, we're following women long-term after pregnancy to understand what the risk of autoimmune disease is. So we looked at all women who were of reproductive age over a 20-year period between 1998 and 2018. And we excluded women who had any sort of history of mental illness, as well as those who had a history of autoimmune disease, so that when they entered the cohort, the first thing we did was assess their sort of new mental illness status, whether that was present or not, and then follow them forward over time to ascertain risk of new autoimmune disease. So based on their mental illness status when they entered the cohort, we classified them as having mental illness arising in the perinatal period, mental illness arising outside of the perinatal period, or not having mental illness. And then we followed all three groups over time. And again, we followed them to ascertain autoimmune disease status. And we also broke this down again, sort of within the confines of administrative data to try to understand autoimmune diseases that may be more likely to impact the brain or to have sort of brain-associated disease characteristics like multiple sclerosis. So you might think that that relationship would be stronger for mental illness if there is sort of a brain link. And so what we see overall, so this is looking at the cumulative incidence or sort of the incidence over time of autoimmune disease in our 3 groups of interest. The perinatal mental illness group is the solid black line towards the top. Then we have our group of mental illness outside the perinatal period, which is the sort of uneven dashed line that overlaps with the solid line. And then we have our no mental illness group, which is the lower line that's kind of the evenly spaced dashed line. And so right away, you can see that there's elevated risk for autoimmune disease in women with perinatal mental illness over time, but that risk appears to be about the same as the risk of autoimmune disease in women with mental illness arising outside the perinatal period. And I'll talk a little bit about why that's important. But both groups appear to be at increased risk compared to women without mental illness. This is sort of that same figure shown another way. So in other words, the hazard ratio, these are interpreted the same as relative risk, but basically the hazard or the risk of autoimmune disease comparing perinatal mental illness to no mental illness was about 1.5. But comparing perinatal mental illness to non-perinatal mental illness or mental illness arising outside the perinatal period is approximately 1. So in other words, no real difference between those 2 mental illness groups. So in other words, mental illness increases the risk of autoimmune disease regardless of whether onset is in the perinatal period or outside the perinatal period. And this is after matching on a number of other characteristics that could account for these relationships. Okay, so then, as I mentioned, we were also interested in whether the relationship was even stronger when we look specifically at autoimmune disease with some sort of brain-related activity. And again, what you see is that it's an even stronger hazard ratio comparing perinatal mental illness with no mental illness, with a hazard ratio of about 1.7 compared to the overall one of about 1.5 that we saw before. But again, there's no relationship really between perinatal mental illness and non-perinatal mental illness in terms of the risk of future autoimmune disease. Okay, so again, evidence to suggest that the relationship that we're interested in between chronic physical conditions and mental illness could flip the other way around, such that mental illness is a risk factor for future chronic disease. So what does this all mean in terms of tying together findings from, diverse but related studies? So what's our summary of findings? So what we're basically saying is that there's a consistent evidence of an association between chronic physical conditions and perinatal mental illness. As suggested in research outside the perinatal period, it appears that this relationship is likely bidirectional in nature. We looked at this relationship in both directions, and we showed that pre-pregnancy chronic physical conditions increase the risk of perinatal mental illness and addiction, even after accounting for pre-pregnancy mental illness. So we're seeing an increased risk for new onset and relapsing mental illness associated with chronic disease. And likewise, perinatal mental illness appeared to increase the risk of incident autoimmune disease compared to no mental illness. So again, showing increased risk for new disease in the opposite direction as well. And so what are the possible reasons for these findings? So as I mentioned at the start of the presentation, there's quite a bit of research from outside the perinatal period looking at potential relationships between physical conditions and mental illness, and showing that there is a role for inflammation, for vascular pathology, for dysfunction related to the HPA axis. We also know that there's kind of a social and a stress association in terms of the management of the disease itself, or other symptoms related to the disease, such as pain or sleeplessness. And as I said, also there is some interesting work being done on shared genetic factors. So for example, there's a study that was done a number of years ago looking at shared genetic factors between diabetes and depression, which suggests that there could be some sort of shared underlying etiology for these conditions that we need to pay attention to. But I think it's important to mention and to sort of think about the fact that we're looking at these associations in our study using administrative data. And so the real power of administrative data is the really large sample sizes that we have available to us, where we're dealing with sample sizes in the millions. And so we're able to follow large groups of people over time. We're able to look at rare outcomes such as autoimmune, specific autoimmune diseases even. And we're able to sort of tease this out in large groups. However, the downside of that is that our information is somewhat surface level in some ways, and that we are relying on medical records and what's collected as part of medical records to understand these associations. And so one of the first questions that comes up in this research, especially when we consider the fact that all of the relationships were not gigantic effect measures. We're not dealing with relative risks or hazard ratios of 3 or 4 or 5. We're dealing with relative risks and hazard ratios of between 1.2 and 1.7. So the question is, could those relative risks be explained by some sort of ascertainment bias, where if a physician knows that you have a physical condition, are they more likely to screen for and therefore detect mental illness? And likewise, if they know that you have a history of mental illness, are they more likely to screen for and detect a chronic physical condition? So I didn't present the data here, but I will say that we did a number of sensitivity analyses to try to tease this out. And one of the things that we did was to look at whether the relationships that we saw hold in both outpatient and inpatient settings. Because you would think that the majority of sort of ascertainment bias and screening and detection bias would occur in an outpatient setting, where a physician says, okay, I'm seeing you for one reason, I should look and see if you have something else that's going on. Whereas if you're presenting, on the other hand, to an emergency department or to a hospital and you're being hospitalized, if that relationship also holds there, especially in relation to mental illness, you would think that that's a crisis important enough that that reveals a real relationship that's going on, and not simply the case of ascertainment bias. And indeed, what we did see is that all of the relationships that we looked at across these 3 studies held in both outpatient and inpatient settings as well, and emergency settings. Another major limitation that we have with this work is an inability to measure mental illness severity. It would be really great if we had some sort of measurement of symptoms to see if also symptomatology is even worse associated with chronic physical conditions, but all we have available to us is diagnoses. And on that note, because all we have available to us is diagnoses, we don't have any information on untreated mental illness. So we know that there's a proportion of the population that we're missing, and a group of women who are experiencing symptoms who never present in a healthcare setting, and therefore those people are missed. We're able to account for a number of covariates in our analyses, including age, parity, neighborhood level income, and other sort of comorbid chronic conditions. But in this study, we were not able to look at medication. And as well in administrative data, it's really not possible to measure things like smoking, obesity, or race and ethnicity, which of course could have an impact on the types of relationships that we're seeing here. So those are important limitations to keep in mind as well. However, again, when we're studying relationships where some of our variables are rare, or where we need to follow people over considerable amounts of time to look at the outcomes, despite these limitations, our population-based data do offer us with advantages that we really wouldn't be able to have if we were to prospectively collect some of these data. So we have to sort of weigh up the pros and cons when we do this kind of research. So a couple of thoughts on the clinical importance of this. So again, outside of the perinatal period, what we're seeing is growing evidence of a bidirectional association between mental and physical illness. And so if that relationship does extend to the perinatal period, which it appears that it does, this really shows that the perinatal period could be a time of particular vulnerability for new onset conditions where women could really benefit from clinical support. It's also really interesting to think about it in terms of the opportunities. So compared to any other point in their life course, women are well connected to the healthcare system in pregnancy and postpartum, right? When else do you see your doctor? Every couple of months or weeks. And so this is a real opportunity to make a difference in terms of, putting people in touch with the supports that they need, as well as connecting them more broadly to the healthcare system. So I personally find it, extremely interesting to think about the perinatal period as an opportunity at a point in time in the life course when you can really change a person's health care trajectory and their health trajectory. So specifically, what does this mean? Well, I think when we think about chronic conditions as a risk factor for perinatal mental illness, this does suggest a need for perinatal mental health screening and support in women. So thinking about this from a preventive standpoint, if we can turn supports towards groups that have increased risk, perhaps women with chronic physical conditions should be included in that, high risk group. And they should also be considered a group that should be screened for perinatal mental illness regularly. Likewise, thinking about the third study that I mentioned, perhaps there's a need for early detection of chronic disease in people with a history of perinatal mental illness. And I say here, in people with a history of mental illness broadly, because of course we did find that the risk associated with perinatal mental illness for autoimmune disease was similar to the risk associated with non-perinatal mental illness. But this in itself, I think, is a really interesting finding, because previously we thought about perinatal mental illness as this time-limited, experience for women that perhaps sort of didn't have long-term implications. But what our data really suggests is that, perinatal mental illness was just as important for predicting the risk of subsequent autoimmune disease as mental illness at other points in the time in a person's life course. And so perhaps this is a group that could benefit from screening as well. And both of these findings together, I think, really speak to the importance of multidisciplinary collaborative care. There's been a lot of research, again, in the general population suggesting that when people receive mental and physical health care from the same team, they tend to have better outcomes, both related to their physical condition and also related to the management of their mental illness. And so this really does suggest that the same sort of benefits could be seen in the perinatal period if we think about co-locating physical health care providers, such as obstetricians, with mental health supports. And so I think this really sort of speaks to the importance of providing that multidisciplinary care. So I'll just end off by thanking my co-investigators, Cindy Lee Dennis, Astrid Gutman, Joel Ray, and Simone Vagode, as well as our funding from CHR, the CRC program. And I think we have some time left for questions if there are any.
Yay, thank you so much. Thank you. Yes, I encourage the little clap emojis because it's always nice to get the auditory feedback, but the emojis will take in the interim. And I should have mentioned before, of course, please feel free to ask a question in the chat, or if you are feeling brave, which you should feel brave, you can unmute and ask your question yourself. So I have some questions myself until I see some pop up. But thank you so much for that lovely talk. I really appreciate the clinical implications at the end of your talk. That was really important for, I think, lots of people to hear, because I think there's some really great advice in there. And I love the idea, I love the reframing of, instead of thinking about it only as a vulnerability or susceptibility time, that opportunity, because certainly, myself and any of you that might have experienced pregnancy and the postpartum period, you have a lot of appointments with that. You have basically no time for anything else. So it is a really important time to communicate with your healthcare practitioners. So my first question is, have you looked, I appreciate that you looked at, controlled out for parity. I'm wondering, I guess I could say, did any of that matter? Did you look at the strength of the covariate? Did that matter? And then another one I'll throw in is fetal sex, because if you're pregnant with a a male, it's supposed to be a little more, what's the word for it? You'll get a stronger immune response, let's just say. And so is that associated with a greater risk? And have you looked at that at all in any of your work?
Yeah, that's a great question. So starting with the parity one, so parity didn't seem to make a difference. We thought that it would as well. It was a significant covariate, but it wasn't one of the stronger ones. And controlling for it, the relative risks dropped whenever we controlled for things, but it wasn't sort of the main piece that was driving it. Really was, I'm trying to remember, but it was, the biggest drop was related to history of mental illness, of course, as you would expect. And then I think the second biggest, I think it was neighborhood income quintile, but parity didn't really seem to make a huge difference. In terms of fetal sex, I'm actually waiting for an update from my analyst because we did add that as a sensitivity analysis, but I don't have the numbers yet. I was hoping I'd have them for today, but for sure that could absolutely make a difference, especially thinking about it from that kind of autoimmune kind of reaction sort of note. So I'll have to update once we get the data back.
I'm just super excited to hear what if it does, because there's such little of it, like data out there, even just looking at fetal sex as a factor. And I noticed this, I didn't write this down, but just when you were talking about it, of course you did singleton births, which is certainly the way to go, but I'm wondering if you have any thoughts about, because I don't know, like, is there even more of a response, or you'd think more of a burden physiologically to pregnant people if they're pregnant with twins or triplets or
absolutely. In fact, I'm a committee member on a thesis where the student is looking at the impact of twin pregnancy on perinatal mental illness risk. And what she found was that there is increased risk in the immediate perinatal period. She actually looked long-term to see if it lasted. And I don't think I'm giving anything away by saying this, but what she saw was sort of an increased risk immediately that sort of, decreased a little bit over time. We tend to exclude multiple births for more of a statistical point, because it sort of the clustering of twins together within a pregnancy can sort of add a layer of clustering that can impact your confidence intervals. So we had been excluding them for that reason, but I think the student's thesis has made us think differently about it, because, especially when we think about it in the context of aging women and assisted reproductive technologies, and you're more likely to have a twin, you're also more likely to have a chronic disease. And so maybe we are excluding kind of a subset of the population that could have a different experience, but we haven't had a chance to kind of add them back into the cohort yet. It's a good question.
Yeah, that would also be interesting in terms of assisted births too, because maybe that also is associated with so many things. That's the thing. There's a whole career there, Dr. Brown. What about things like, and I probably should know this, if there is data out there, but what about maybe it's I'm sure you thought about it, like just other kind of complications during pregnancy. So gestational diabetes, so you looked at diabetes beforehand and if that increased the risk for perinatal mental illness, but what about complications during pregnancy itself? I think there
there is some research to suggest that there is a role. And in fact, one of my trainees had looked at she looked at the overall association between chronic disease and perinatal mental illness. And then she also looked at the extent to which pregnancy complications explained it, with the idea that if you have a chronic condition, you're at increased risk for complications in pregnancy. And so potentially, is that what's going on as opposed to the chronic disease? And it didn't actually meaningfully explain the relationship, even though on their own, those complications are, like gestational diabetes, as you mentioned, they are risk factors for perinatal mental illness. So I guess I'm sort of answering your question and then also going on a bit of a tangent about it, but essentially the complications do carry a risk for perinatal mental illness independent of chronic disease. They don't explain the association.
No, that's perfect. Thank you. And apparently if you wait long enough, the audience will ask questions, but it's so hard for me to have dead space. But if anybody has, I'm going slowly, otherwise I will ask my other questions. And there's one from Twitter too that I can ask you
Oh, great.
as well. So but I'm going very slowly. No. What about, so one thing that I'm really interested in the whole idea of the autoimmune disorders, because it seems in some ways like, when I first heard you speaking, I was like, that just makes so much sense, just because of all the sort of immune disruptions, shall I say, during pregnancy and the postpartum. But at least with MS, and I know you looked at brain, so then I guess another one would be, well, like, and I'm sure you probably did you look at systemic? You'd expect that brain would be more, linked to mental illness, but was there anything that struck you in terms of systemic? And then
Yeah, so they were all, so we sort of looked overall, and then according to a couple subgroups that we could look at in terms of sample size, and everything was significant. We couldn't really get down into the nitty-gritty of some individual autoimmune diseases, just because even though we start with so many people, the numbers do get lower. But yeah, they're all related, which is interesting. It gets harder to interpret though, because you start sort of asking, some relationships do seem to be stronger than others, but how much bigger does the strength of the association need to be for it to be meaningful? And so we try not to overinterpret it. So the sort of overall take home was that any autoimmune disease was associated with mental illness in the perinatal period. But one of the things we've been thinking about doing as a next step is to really try to tease apart the potential mechanisms for each type of autoimmune disease, and really whether we are seeing heterogeneity in risk. So that's something that we're working on right now.
That's really, because I think that is a really interesting question in of itself. And for those of you, maybe many of you on the talk already know this, but starting to dabble in this, not the same area, but looking at immune responses or immune signaling during pregnancy and the postpartum, and how it might impact mental illness, the kind of questions that we are sort of looking at. There's surprisingly not that much work or even known about immune signaling during pregnancy and the postpartum, which is kind of shocking to me. One of the things that I hear about is that with MS, with multiple sclerosis, so this is somebody that's already been diagnosed with multiple sclerosis, they actually go through remissions, I think, during pregnancy, right?
Yes.
So it's kind of like this.
Yeah, and it's confusing because there's some autoimmune diseases that get better in pregnancy and then flare immediately postpartum, which is what you would sort of expect them to do, because there's kind of a lowered immune response during pregnancy. But then there's others that seem to get, like, I think lupus gets worse during pregnancy and tends to get a bit better immediately after delivery and then kind of flare again. So there's obviously other things going on that, even outside of the relationship with mental illness, still more work needs to be done to understand it. So it's quite complicated. Yeah.
Okay, we have a question from the audience. Perveen, did you want to unmute yourself? If you can, you might, if you're still on the call. I'm trying to see if I can see your.
Oh, I suppose I could unmute myself. Sorry, I'm just on video. So I'm from industry, I'll fully admit. I'm a medical science liaison, so I support both women's health and immune diseases. So I find it really interesting that you talked about the immune compromised patients having a greater risk, because one of the things that's been studied is that patients who have RA or psoriatic arthritis do tend to have a higher risk of mental illness, but when they take things like TNF inhibitors, that helps. So TNF inhibitors have been studied to see if they work with depression. So I was wondering if you looked at, those patients who are taking biologics like TNF inhibitors, and if they had a different outcome, or if there was any relation with the TNF inhibitors or other biologics.
Yeah, that's a great question. And I've read similar things that some, like you said, medications that work for autoimmune disease also work for depression. So in Ontario, we only have medication information on people who are also on social assistance. It's just the way, like, only the people who get kind of provincial level reimbursement for medications have their data recorded. And so that's just kind of I think it's 7 to 10% of the population. And so we hadn't looked at that yet for that reason, because it does sort of decrease our sample so much. But it has been a question on my mind and on our team's mind of, what role does medications play? So it's something that we should do. We just need to figure out if we have the sample size to do it.
Well, thank you. I'm so excited that we had a message from the audience, actually. And then I guess we have time for one more. So there's a couple on Twitter, but the one that came up on my feed is, what are the complications? What are the implications? And I think you sort of alluded to this at the very beginning. I think the screen went dead, of course. What are the implications for the healthy growth of the fetus and child long term? Like, are you thinking about looking at, because I think part of your work is also on early development too. So do you look at any of that right now, or are you planning to in the future?
Yeah, we're planning to. So I have a PhD student who just started, who's going to look at the combined impacts of physical and mental illness on sort of neonatal outcomes and hopefully child outcomes as well, with that idea that we know a lot about these two conditions or groups of conditions separately, but what happens when they co-occur, and do they sort of have an exacerbating kind of effect on some of the outcomes that we see associated with one or the other? So there hasn't been a ton of research in that area. I know there's enough to sort of suggest that yes, having comorbid physical and mental illness together could have an even greater impact on the child. But as we get in 4 years and all, I'll get her to come present. Yeah.
Sounds great. Well, thank you. I just want to say, just again, thank Dr. Hilary Brown for a fantastic presentation. Really great to have I'm going to call you an early career researcher because you are, but a really great body of work. And we thank you so much for your time. So
great. Thank you so much. This is great.
Well, the pleasure's all ours because we got to sit back and listen. And hopefully I didn't read anything wrong.
Oh, that's wonderful. Thank you so much.